All right, let's dive right into this explainer. We're unpacking the wild, often totally misunderstood world of skeletal muscle relaxants. If you've ever thrown your back out, you know exactly how desperate that search for relief can be. I mean, millions of adults turn to these medications every single year, just praying for a quick fix to all that pain and stiffness. But what does the latest clinical data actually reveal about treating back pain with these drugs? Today, we're looking strictly at the peer-reviewed evidence to separate the medical facts from the everyday myths. Here's our roadmap for this explainer. We'll hit the muscle relaxant mystery, look at spasms, spasticity, and pain, check out the menu of medications, weigh the side effect trade-off, get the verdict on back pain, and finally, compare acute versus chronic use. Let's get into it. Section 1. The muscle relaxant mystery. So what do skeletal muscle relaxants actually do? It's the most fundamental question we have to ask right out of the gate. Because for a drug class prescribed to millions of people, how they actually work is, well, surprisingly mysterious. The name muscle relaxant kind of implies that the pill goes straight to your tight lower back and magically loosens those specific muscle fibers, right? But as we'll see from the clinical literature, that intuitive assumption is just dead wrong, and it leads to a ton of clinical confusion. Dr. Wilson Chang really hit the nail on the head in his 2020 review. He basically stated that these agents are incredibly poorly defined. We use them for tension all the time, but the crazy part? We rarely know how most of them work outside of animal models. On top of that, a lot of the foundational science relies on FDA comparison studies that are over 30 years old. So we're dealing with a class of drugs that doctors prescribe literally every day, yet the underlying science of how they operate in the human body is still super murky. Moving to Section 2, spasms, spasticity, and pain. Okay, to truly understand these drugs, you first have to understand the vastly different problems they're meant to treat. Look at the stark contrast here between two conditions that sound similar but are physiologically worlds apart. On the left, you've got a spasm. That's an involuntary contraction, usually from a peripheral issue, like you sprained a muscle lifting a heavy box. You get sudden jerks, twitches, or cramps. On the right, you have spasticity. That is an intense, velocity-dependent stiffness caused by a central nervous system dysfunction. We're talking brain or spinal cord injuries. Treating a simple pulled muscle is a completely different ballgame than treating a spinal cord injury. And then, just to add a third layer to the confusion, we have myofascial pain. This is chronic pain stemming from a mechanical soft tissue injury, usually centered around a top band of muscle, often called a trigger point. The root cause is peripheral, but it causes localized or even referred pain with all sorts of complex sensory symptoms. When you look at these three distinct categories, spasm, spasticity, and myofascial pain, you can see exactly why prescriptions can get mixed up so easily. If you give a heavy-duty drug meant for central nerve damage to someone who just pulled a muscle in the yard, you're going to run into problems. Section 3, a menu of medications. So let's dive into the actual pharmacological menu we use for these very different problems. The meds we casually lump together as muscle relaxants actually fall into distinct targeted buckets. On the left, you have anti-spasticity meds like baclofen, built for severe central nervous system disorders. Over on the far right, you've got antispasmodic meds like cyclobenzaprine, which are generally aimed at everyday musculoskeletal spasms. And right in the middle, dual property medications like tizanidine that cross over to tackle both. Categorizing these correctly is literally step one for any evidence-based treatment. Now, check out this breakdown of how they actually work. Do you notice a pattern here? Almost none of them work directly on the muscle itself. Metaxalon is a sedative that acts centrally. Cyclobenzaprine is basically a chemical cousin to tricyclic antidepressants. It blocks motor neuron signals right in your brainstem or spinal cord. Diazepam, that's a GABA agonist that slows down neuronal firing in your brain. Aside from very rare exceptions, skeletal muscle relaxants do not relax your muscles at the tissue level. They go straight to your brain and spinal cord, and they just turn down the dial on your entire nervous system. Which brings us to Section 4, the side effect trade-off. Because these drugs hijack your central nervous system rather than your actual muscles, we're faced with a massive clinical trade-off. The side effects are seriously no joke. Carisoprodol breaks down into a Schedule 4 substance, meaning it carries a huge risk for dependence and abuse. Cyclobenzaprine gives you severe anticholinergic effects like dry mouth and urinary retention, and it can even trigger serotonin syndrome if you mix it with antidepressants. Diazepam is highly addictive with brutal withdrawal risks. Even tizidine, which works pretty well, burns out so fast in your system that you have to take it constantly. The bottom line from the medical literature is clear. When you pop these pills, you are hitting your whole neurological system with some very heavy baggage. Section 5, the verdict on back pain. So we arrive at the million-dollar clinical question. Does the benefit actually outweigh all that neurological baggage for standard low back pain? To answer that definitively, we aren't just looking at one or two tiny trials. We're turning to a massive 2025 systematic review and meta-analysis published in the European Spine Journal. They evaluated exactly 7,531 participants across 50 controlled trials. This is the absolute gold standard of data, giving us the statistical power to see what's actually happening to people taking these drugs. The great news for acute sufferers, meaning you've had back pain for less than 6 weeks, is that these drugs do actually work. The data showed a 53% risk ratio regarding the lack of pain relief. In plain English, taking a non-benzodiazepine muscle relaxant gives you a moderate certainty of a significant, scientifically backed boost in pain relief and mobility within the first 5 to 7 days compared to taking a placebo. So for a quick short-term flare-up, the efficacy data is totally on your side. But here is the catch. That pain relief comes bundled with a massive, statistically significant spike in side effects. Compared to the placebo group, patients taking non-benzodiazepine muscle relaxants saw their relative risk of total adverse events jump by 56%. And even more concerning, the risk of central nervous system adverse events skyrocketed by 140%. That means patients were nearly 2.5 times more likely to deal with dizziness, intense drowsiness, and cognitive impairment. Interestingly enough, there was almost no increase in stomach issues. The damage, the side effects, are almost entirely centralized right in your brain. Finally, Section 6, acute versus chronic use. This is where we see a huge disconnect between what the science says and what patients actually do in the real world. The clinical guidelines are crystal clear. Acute use under 1 month is supported by the data. It helps with short-term relief so you can get back to physical therapy. But get this, when you look at the survey data, a staggering 44.5% of people taking muscle relaxants stay on them for over a year. The average is actually over 2 years. That completely flies in the face of the clinical evidence. There is absolutely zero data validating long-term usage for chronic back pain. Chronic use just massively cranks up your risk for oversedation, dependency, and severe CNS depression. So based on all the rigorous evidence we've unpacked in this explainer, I want to leave you with this final thought. If you're suffering from a temporary back spasm, a short course of these meds might genuinely just help you get through the week. But knowing that they're basically sedating your brain, not fixing your muscles, and knowing the steep cliff of dependency and brain fog that comes with long-term use, is that promise of short-term back pain relief really worth gambling with your long-term neurological health? It is a conversation you absolutely need to have with your doctor. Thanks for joining me on this explainer, and stay curious.